días. Buenos días. Por favor, tomen asiento. Esta sesión va a ser en inglés. Welcome. It's for us a pleasure to have this session that is on hot topics in cardiology. My name is Lina Badimon. I am the Vice President of the Society, and co-chairing with me is Dr. Rodriguez Padial, who will be the next Vice President of the Spanish Society of Cardiology starting tomorrow. So we have invited experts in different areas of cardiology, and it's our great pleasure to introduce the first speaker, Dr. Fonarov, that will speak about the strategy of application of the guidelines of the American Heart Association in the USA. So, Greg? Before you start, let me say something interesting and important. This session is produced on webcast, and we will be able to accept questions from people not being in this room, not being present at the conference through Twitter. And we have helping us for this task of receiving questions and filtering questions to us, Dr. Juan Quiles, Dr. Jose Juan Gomez de Diego, who is somewhere. Can you show? Here. Okay, he's sitting there. And Dr. Agustin Fernandez Cisnal, also sitting here. So they will be actively communicating with the outside, and then we will get this interaction with people that are following our conference from outside. So with no more, Greg, please go ahead.
Thank you very much, distinguished chairs and presidents, and ladies and gentlemen. It's a great pleasure to be here to present on this topic regarding the American Heart Association's Get With the Guidelines strategy. Measuring and improving the quality of cardiovascular care is of global importance, as cardiovascular disease remains a major public health problem, resulting in substantial morbidity, mortality, and healthcare expenditures worldwide. Fortunately, we have a number of evidence-based guideline-recommended therapies that are available for patients with cardiovascular disease and prevent first and recurrent events and reduce this morbidity and mortality. However, study after study shows inpatient setting, outpatient setting, country after country, that these available therapies tend to be underutilized in eligible patients, and thus many patients are having clinical events that could have been prevented with higher quality of care and better implementation of these therapies. In the United States, data shows that more than half of patients with heart disease and stroke do not receive care that is consistent with the current ACC and AHA guidelines. So while we have the evidence, we have the professional standards, often they are not routinely applied in clinical practice, often due to lack of systems to ensure highly reliable care. So traditionally, professional societies have been involved in helping to generate the research, having scientific sessions such as this, developing guidelines and statements, and maybe even performance measures. But the translation and implementation into clinical practice was really left to individual clinicians and healthcare delivery systems, with the hope then there would be improved clinical outcomes. But with these large treatment gaps, the AHA recognized needed to become involved in the actual implementation efforts to ensure high quality care if the mission of reducing cardiovascular disease and death would actually be met. So what is Get With the Guidelines? It's really designed about reducing the gaps and variations in the quality of care and to have collaborative efforts to improve the quality of care for patients with cardiovascular disease. In short, take the evidence and therapies we have that are strongly recommended in the guidelines, ensure they are routinely implemented into clinical practice by creating performance improvement systems to implement the evidence-based care, improve communication among all of the healthcare providers, and ensure compliance in a way that will improve quality of care and ultimately improve clinical outcomes for patients. So this is really a collaborative effort where the professional organization works with individual physicians and hospitals together to provide the science around implementation of evidence-based therapies and uses a web-based patient management tool where clinicians can check the patient's care with the current version of the guidelines and ensure that care is concordant. In addition, get real-time feedback on how they are performing and provide up-to-date patient education. So, higher quality of care, customized education for the patient, improved communication among healthcare providers, up-to-date prevention strategies, all with the goal of reducing death and disability due to cardiovascular disease. We also know patients are 10 times more likely to adhere to secondary prevention therapies when it is started in the hospital after a cardiovascular event than waiting till try and start as an outpatient basis post-hospital discharge. Under the suite of programs for Get With The Guidelines from the AHA are a variety of modules focusing on different disease states: acute myocardial infarction, atrial fibrillation, coronary disease, heart failure, stroke, and a variety of other programs to improve the quality of care by accrediting and certifying cardiovascular hospitals. The core principles of Get With The Guidelines are shown on this slide. The focus is collaborative quality improvement. Success is in translating the evidence and guidelines into routine clinical practice, capturing this teachable moment. Data drives the change, so it's very much about collecting performance data and improving on it one hospital at a time and sharing best practices across a network of all U.S. hospitals. So who's involved in building the quality improvement system and hospital team? This is a collaboration between physicians, nurses, pharmacists, hospital administrators, directors of cardiac services, cardiac rehab, and even pre-hospital emergency medical services for timely care. Here is the AHA Get With The Guideline web-based patient management tool. So any hospital with an internet connection can collect data with simple clicks regarding the patient's key demographics and the interventions and interactively check that care with the guidelines, real-time feedback. They can track performance over time as well as deliver printed out, personalized patient education materials, how to quit smoking for those where it applies, and so forth, and education around each of the medications, and diet, and exercise, and referral to cardiac rehab. There are opportunities for networking and sharing best practices where the hospital team members all work together to learn about the program and share their experiences. 78% of the U.S. population is within reach of the over 2,000 hospitals currently participating in Get With The Guidelines. And this about half of the U.S. hospitals are participating in one or more of these modules. So there is a true population impact. There have in fact been more than 12 million cardiovascular disease patients that have been entered into the actual quality database since inception in the year 2000. Let me show you some of the performance impact of the program. In blue is showing the data at baseline as hospitals were signing up. In pink, the data after implementation of the program, and you can see for quality measures such as aspirin during acute MI, beta blockers, use of statin therapy, smoking cessation, there were substantial improvements. And this overall defect-free or 100% compliance measure where patients received all therapy they were eligible for started off at baseline below 60%, has risen up to close to 90%. Certainly we would love to be at 100%, but there's been marked improvement in the quality of care. This is data for heart failure, where you can see the improvement on the use of things like beta blockers, ACE inhibitor, and ARBs, and that overall performance now up at for defect-free care, close to 95% of eligible patients receiving every therapy the guideline says they should be on prior to hospital discharge. Remarkable improvements in performance. Get with the guideline stroke. Look at TPA use in the first 3 hours at 30% before the program. This is now up to close to 90%. And also defect-free care, proving less than 50%, up to over 90%. So across multiple cardiovascular disease states, impressive improvement in performance. This is data representing thousands of hospitals, hundreds of thousands of patients, and tens of thousands of physicians and nurses all working together to improve the quality of care. Does Get With the Guidelines improve quality? Does it truly work to improve quality and outcomes? Here is an analysis looking at hospitals participating in the program versus not. Lower mortality rates in participating hospitals compared to non-participating hospitals in the exact same time frame. Get With the Guideline truly works to improve quality of care and clinical outcomes. Here is further data. With every 10% improvement in guideline adherence for acute coronary syndrome, about a 10% reduction in in-hospital mortality. So translating the guidelines into routine clinical practice translates to improved clinical outcome. Here is data from a prospective initiative to improve the timeliness of treatment with TPA for acute ischemic stroke. Going along, less than a third of patients had a door-to-needle time within 60 minutes as recommended in the guidelines. We initiated, using Get With the Guideline Stroke, a focused quality improvement program. Look at the marked improvement, getting up to 50%, and in fact, clinical outcome improved, less disability due to stroke, lower in-hospital mortality, therapy was safer. Here is data on a nationwide impact using Medicare data. This is all older adults hospitalized with AMI, heart failure, and ischemic stroke in the US since Get With the Guidelines started and over the next 10 years. And you can see substantial improvement at the national level in clinical outcome for these patients. This is data on the number of publications generated from Get With the Guidelines. To date, over 300 peer-reviewed publications in some of the highest impact journals. So this can be a valuable resource for actual research and publications. There is also the ability to take the registry data from Get With the Guidelines, link it to longer-term follow-up, and perform comparative and clinical effectiveness research. Here is a few of the examples of the type of research that has been generated from Get With the Guideline registry data, and to compare different therapies for what will improve the outcomes and generate the next generation of guidelines with regards to what therapies truly work for patients. What are the key elements to quality improvement? They're shown here. Many of these aspects are critical to truly have meaningful quality improvement. Access to current and accurate data on treatment and outcomes, dedicated physicians who will volunteer and work on this, champions, who gain support among clinicians, having stated goals, administrative support, use of pre-printed orders, clinical decision support tools, and critically important, use of reliable data on performance to provide feedback. What's next for the AHA quality improvement initiatives? So there is a process where we are working on transforming guidelines into practice much more quickly, where they can be deployed electronically and immediately get into the quality improvement programs. And given how well this has worked in the United States, are working internationally in collaboration with a variety of professional organizations and government ministries of health to create a global collaboratory where we try and take quality improvement initiatives worldwide, working together with the local physicians and local leadership to try and share best practices so that all patients with cardiovascular disease worldwide can benefit from such programs. And this is aligned with the global vision of trying to, by 2025, reduce cardiovascular disease and death in alignment with the World Health Organization by 25%. Over 190 countries across the world are all working together to reduce cardiovascular disease incidence, and improving quality of care can help us do this. So these international guiding principles are shown here. Collaboration across societies, building capacity, providing critically important, culturally appropriate care that's based on the local guidelines, not applying international guidelines to care, but the local cardiovascular guidelines to make a truly sustainable quality improvement effort that is global. This is where some of the early efforts are taking place: Puerto Rico, Sao Paulo, in Hong Kong, a large Chinese collaborative, Dubai, New Delhi, and so forth. This is efforts that are taking place from the Spanish Society of Cardiology. Recently published this In Cardio Principle statement defining the quality markers in cardiology to measure quality within Spain for clinical practice. And there was an editorial that the AHA supplied to this, Improving Quality of Care, a Global Mandate. So this has truly begun in far as improving quality. To summarize then, there is a cycle by which we need to operate to improve quality care and outcomes, where it's not enough to just have concept, clinical evidence, and guidelines. We actually have to measure how care is being delivered in clinical practice, provide measurement and feedback through quality improvement systems to ultimately improve clinical outcomes, and this can generate new concepts that can be tested in randomized clinical trials. And through this, we can truly improve quality of care and outcomes. So in conclusion, a large treatment gap exists between guidelines and practice for cardiovascular disease, and as a result, a large number of patients are having recurrent fatal and non-fatal events that could have been prevented with better implementation. Performance improvement programs like Get With the Guidelines can significantly improve the use of these key evidence-based therapies, and as a result, reduce death, disability, and even costs due to cardiovascular disease. And there are substantial opportunities for collaboration between professional societies to further advance quality improvement globally. Thank you so much for your attention today.
Thank you very much for a very good presentation. Is there any questions? We have one that came through Twitter that coincides with one I wanted to also to ask you. I mean, how is this program permitting in the US? I mean, are all the hospitals that you say that are involved in Get With the Guidelines providing information on quality of care and event reduction and performance? Or is it a selection of these hospitals only?
So it's a great question. In the US, there is actually a requirement from the federal government that certain quality measures get publicly reported. However, participation in Get With the Guidelines is voluntary. The hospitals sign up, agree to share their performance data, and send that data in a very compliant fashion where there's security and data checks to the AHA, and that performance patient management tool provides feedback. They do not necessarily have to have their data publicly reported. They see their own data. Other hospitals do not see other hospitals' data. But this is all voluntary. But that said, over 2,000 of the 4,000 hospitals in the US have volunteered and have benefited with the improvement in quality and outcomes for their patients.
And I guess this is a trend increasing, right? More hospitals want to get involved if the results are coming.
Yes, so in fact, when we first started in the year 2000, there were only 29 hospitals that piloted the program, and it has steadily grown. Our ultimate goal, we would love to have all US hospitals participating.
Right. Is there any question? Oh, okay, go ahead. What is it?
Yes, here. Ramon Brugada, Hospital Trueta, Girona. I have a question. Have you seen any difference between, stick to the percentage of individuals, not hospitals, but individuals sticking to the guidelines according to whether they are insured or non-insured in the US? And second, some of the guidelines are simple, given aspirin, I mean, that's simple. Implant an ICD as a primary prevention, that's not something that every country can afford. So how do you plan to deal with these two issues? Thank you.
Both are excellent questions. We have actually studied by insurance status and the uninsured, at least within the hospital, that the sort of 5% or so with no insurance do receive comparable quality of care for those medications that are widely available. Certainly for more expensive therapies, it has to be country specific. In the US, those with insurance, there is broad coverage with regards to cardiac resynchronization and ICDs for heart failure. Certainly in other countries where there may be limitations, that would be something that could be decided would not be part of the performance improvement initiative because it would not be economically viable and sustainable. So I think it is very important that all quality improvement initiatives be in the context of the local guidelines and the local healthcare delivery system for what is viewed as offering good value and ultimately improving outcomes in a way that provides good value and is cost effective and most importantly sustainable for the overall healthcare delivery system. Thank you so much.
Okay, thank you, Dr. Fornaro, for your nice talk. If we have more questions, we can keep them to the end of the session, so we have more time to get them through Twitter. And now let's move on to the next talk, that is going to be sudden death in patients with cardiomyopathy who is at risk. And the speaker is Juan Manuel Aranda from Florida, Estados Unidos.
Click here. It's a true pleasure to be here today and continue our special relationship between the Florida chapter of the American College of Cardiology and the Spanish Society of Cardiology. Over the last 4 years, myself, Dr. Juanate, Vicente Bartolome, we have developed a true relationship, special colleagues, and it's a true pleasure to be here. So we're going to change gears a little bit and talk about sudden death and in the new onset cardiomyopathy patient. My main disclosure is que originalmente yo soy de San Juan, Puerto Rico. Y we have a special, and excuse me for my Spanglish, but it's a great opportunity. But we have a special relationship with Spain, but I think we can apply this to heart failure. Asking physicians to talk about sudden death and heart failure is like asking Puerto Ricans to agree where Cristobal Colón discovered the island of Borinquen. 4 different cities, 4 different statues arguing where Cristobal Colón landed. So when we talk about heart failure, every heart failure patient that you take care of goes through this journey. At the beginning, new onset heart failure, the quality of life goes down, they have a hospitalization, intensity of care goes up, you put them on diuretics, ACE inhibitors as they're leaving the hospital, that you put them on beta blockers, their quality of life gets better, the intensity of care goes down. But they go through a phase where sudden death actually comes into play. After a period of time, they may qualify, if their EF does not go up, they may qualify for CRT, AICDs. But we're gonna talk about this period of sudden death in those first 3 to 4 months, who actually is at risk. So the problem is that there's no question that beta blockers are great in heart failure. They improve the EF, they decrease mortality, they decrease sudden death, very, very good outcomes. However, sudden death continues to play a role despite beta blocker therapy. And the second problem is, it takes time as you're optimizing the beta blocker, carvedilol 25 BID, metoprolol XL 200 a day. It takes time for the ejection fraction to go up, which is the major predictor, at least from the guidelines, in terms of sudden cardiac death. So our patients, as you're titrating these medicines, the full effect of the beta blocker is still not yet in play. So there's no question that when we talk about AICDs, we heard the question from the audience, when we talk about AICDs as primary prevention, there's no question that this therapy reduces mortality. It is supported by the guidelines. You can see that as MADE-2 came out, SCUD-HEF in the definite trial came out, the use of defibrillators as primary prevention went up both in the US and also in Europe. You can also see that here in Spain, You get it. You are very aggressive in terms of prevention of sudden death, the use of AICDs. There are some regions in Spain that the implantation of AICDs is greater than what in the other European countries. But when you talk about the guidelines, both the ACC, AHA guidelines, and your 2015 European guidelines, you can see that there is a waiting period in terms of primary prevention if your EF does not go up. In the post-myocardial infarction patient, the EF is less than 35%. Both guidelines state that at least 40 days you wait before you start talking about a primary prevention defibrillator in this post-MI patient. And the patient whose EF is low and maybe got bypass surgery or maybe got a stent to their LAD, you wait 3 months. Reevaluate the EF. There's no question that revascularization with beta blockers, your EF may go up, and therefore your risk of sudden death is less. And in the non-ischemic cardiomyopathy patients, somewhere to about 3 to 6 months. But we worry about this. Y I'm going to poll the audience, y lo voy a decir en español. ¿Cuántos de ustedes han tenido un paciente que ha padecido de muerte súbita durante estos periodos que estamos esperando a ver if the ejection fraction goes up? Raise your hand. I've had it. Hay unos cuantos. So this is a problem. There was a paper published several years ago in the US looking at AICD implants for primary prevention in heart failure. And after 111,000 implants, 22% had a non-evidence-based indication for their implants. That means that they violated the guidelines. This tells you that we worry about this. 23% got a defibrillator within the 40 days of their myocardial infarction. 3% got a defibrillator during the 3 months waiting period after bypass surgery. 12% got an AICD with class 4 heart failure. Miren, si su paciente tiene fallo cardíaco clase 4, they don't need a defibrillator. The survival curves of a defibrillator don't diverge until after 1 year. They need an LVAD or a transplant. And 62% had a new diagnosis of heart failure at the time of the ICD. So we worry about this. This is a very difficult period that the guidelines say that you must wait to see if the ejection fraction improves. So who are the patients that are at risk for new onset, for sudden death in that new onset cardiomyopathy patient? Let's begin with the patients that have a myocardial infarction and the ejection fraction is low. There are two studies that address this issue, the Dynamite study and the IRIS study, looking at patients who had an MI within 60 to 40 days, that waiting period that is emphasized by the guidelines. You can see that these trials were designed for long-term mortality benefit. And at 32 months follow-up or at 30 months follow-up in the IRIS trial, there was no difference if you got an AICD as compared to placebo. But in the back of your mind, look at the heart rate criteria above 80. Look at the heart rate criteria in the IRIS trial above 90 and having non-sustained VT. Keep that in the back of your mind as we try to elicit these risk factors for sudden death early on. However, in these trials, if you look there to your left, you can see that early on, if you had an ICD, the risk of sudden death from arrhythmias was less as compared to the control group. Over a period of time, that arrhythmia risk in terms of mortality translated to a non-arrhythmia risk in terms of overall mortality. You have heart failure, it progresses, maybe you get an AICD shock. But what we're trying to address at this moment is during that waiting period, who are the patients at risk for sudden cardiac death? And the same thing in the IRIS trial. Early on, the risk of sudden death was decreased if you had an ICD as compared to control. But overall, after 30 months follow-up, there was no difference in mortality. So the best data that we have in the post-MI patient with a low EF comes from the Valiant trial, which looked at the combination of an ACE and an ARB together in the post-MI myocardial infarction patient. You can see that early on, the biggest predictor of sudden cardiac death was an EF less than 30%, and that risk was most significant in that first month after having your myocardial infarction. So again, that is the transition period that is emphasized by the guidelines that we're waiting to put a defibrillator because maybe your ejection fraction goes up, but the risk of sudden cardiac death is there. From the Valiant trial, we also saw that there are predictors that we can use to better understand these patients. High baseline heart rates. You can see how your hazard ratio increased for every 10 beats per minute that your heart rate was elevated. Impaired baseline creatinine, low EF, and QRS duration. This is the strongest data that we have in the post-MI patient with or without revascularization as predictors of sudden cardiac death during that early transition period. So now let's go to the non-ischemic cardiomyopathy patient, a different patient population. And that non-ischemic cardiomyopathy patient, you have inflammation, myocarditis, autoimmune issues, metabolic issues, a totally different patient when it comes to sudden death after the diagnosis of heart failure. Back in 2003, they looked at T-wave alternons, baroreflex sensitivity. At the end of the day, in 2003, a low EF and lack of beta blockers were the main predictors of sudden cardiac death. You could have told me that before you entered the room. So that is very, very old data. So if you look at the non-ischemic cardiomyopathy patient, there was one trial called the cardiomyopathy trial, small number of patients, 104, new onset non-ischemic cardiomyopathy. At the end of, actually the trial was stopped early because there was no difference between an AICD and placebo and that non-ischemic cardiomyopathy patient with a recent diagnosis. The definite trial looked at patients with non-ischemic cardiomyopathy, and you can see there was a strong trend in terms of reduction from any cause in this patient population. It's interesting that one of the criteria that you had to enter this trial was that you had to have either non-sustained VT or greater than 10 PVCs an hour. Keep that in the back of your head as we try to look for risk factors in this specific patient population. You can see from the definite trial that in terms of risk of sudden death, it was less if you had an ICD as compared to placebo. And subgroup analysis also showed that in the non-ischemic cardiomyopathy patient with duration less than 3 months, there was also a benefit. It's subgroup analysis, smaller number of patients, but again, during that transition period that the guidelines emphasize that we have to be cranking up medicines to see if the ejection fraction goes up. The risk of sudden death is still there. We're trying now to identify what are those risk factors in this specific patient population. So what do you do with this? In the hospital for the first time, asymptomatic, you're starting the beta blocker. Does this predict sudden cardiac death? Well, back from the Jessica trial, back in 1996, randomized to amiodarone versus placebo, they stated that non-sustained VT was a risk factor for sudden death. The use of beta blockers back in 1996 was like 2%. The data suggests that over the years with beta blocker therapy, just having occasional PVCs, non-sustained VT, does not predict sudden cardiac death. And I apologize for the circles and all this. Back in 96, when I was a cardiology fellow, my daughter Evita took my paper and was practicing circles and it messed up the entire article, but that's the copy that I have. So, amiodarone, is that a solution when you have non-sustained VT or a non-ischemic cardiomyopathy early on? We learned from the CHF STAT trial that being randomized to amiodarone as compared to placebo, there was no difference in mortality in patients who had non-sustained VT, and whether you suppressed the PVCs or not, it did not make a difference. Besides the Jessica trial, there is no data that suggests that amiodarone to reduce non-sustained VT, primary prevention, improves your mortality in this patient population. There was an article last year looking at the risk of sudden death in the non-ischemic cardiomyopathy patient. A meta-analysis over 6,000 patients. All the autonomic parameters, baroreflex sensitivity, heart rate variability, did not predict sudden cardiac death. Patients who had enlarged ventricles, there was a strong signal there. Low ejection fraction, there was a strong signal there. Evidence of non-sustained VT, also predicted sudden cardiac death in this meta-analysis, and also QRS duration. The problem with this meta-analysis is that you had publication bias of some very small studies, and many of the studies, although they were arrhythmia specific, the endpoints that they looked at were different. So this is a limitation in terms of this meta-analysis. Last month in Circulation, they published the Wear It 2 registry. This registry looked at patients who were prescribed a wearable cardiac defibrillator. In terms of the doctors thought that these patients were high risk for sudden cardiac death during this transition period, 40 days post-MI, 3 months revascularization, or within less than 3 months of a non-ischemic cardiomyopathy patient. This is sort of what the device looked at. We use this in the United States in patients that we think are at high risk for sudden cardiac death during this transition period. 2 defibrillator pads in the back, 1 in the front, can detect VT or VF and provide the appropriate shock. So here's the data from the Wear It 2 registry. There were a total of 2,000 patients in this registry. 805 had ischemic cardiomyopathy. 927 had non-ischemic cardiomyopathy, and there were some patients that had congenital heart disease. You can see that their ejection fractions were low. A third of the patients have diabetes, and these physicians tried very hard in terms of uses of ACE inhibitors and beta blockers, good therapy during this transition period, trying to protect from sudden cardiac death. What we saw was that out of 2,000 patients in this registry, 41 patients had 122 events for an event rate of 22 event rates per 100 patient years. However, not everybody received the shock. What we're starting to learn is that you may have VT, you may initially have no symptoms, the arrhythmia terminates, and you don't go on to having sudden cardiac death. So actually, those patients that there was a delay where the wearable cardiac defibrillator actually fired for VT or VF, it comes out to about 5 event rates per 100 patient years. To put this in perspective, with all the ICD trials for primary prevention, we learned from MADE-IT reducing inappropriate therapies that with the right programming of a defibrillator for primary prevention, after you've gone through that waiting period, the event rate is about 3 event rates per 100 patient years. So when you put in 100 defibrillators for primary prevention, only about 30 are going to fire, and about half of those are inappropriate. So you can see that the event rate in this registry was actually consistent with the data that we have in terms of primary prevention of a defibrillator. You can see that there's a lot of non-sustained VT. It doesn't necessarily predict sudden cardiac death. You can also see that, in this world now of telemedicine, we have monitors, cardiomems. We're going to detect a lot of things that are happening in our heart failure patients out there in the community. You can see from the registry, there was a lot of atrial fibrillation, non-sustained VT. You can also see that the patients that had ischemic cardiomyopathy, those are the ones that had required the most treatment from the wearable cardiac defibrillator. You can also see that with good beta blocker therapy and neurohormonal blockade, you can see that about 40% or so of patients recovered their ventricular function during that waiting period. The wearable cardiac defibrillator did not fire. The EF goes up, the risk of sudden death goes down. You're out of that transition zone, and you actually do not have a device. And you can see that overall, in terms of the patients that required therapy during this transition period, was about 3% of the ischemic cardiomyopathy patient and about 1% in the non-ischemic cardiomyopathy patient. Now you can sit back there and look, goodness, the incidence of this sudden cardiac death early on is very low. That's what the graph shows. These were all comers to this registry. I can't tell you what is the indication, why the physician suspected that they may be at high risk for sudden cardiac death. The guidelines tell us the transition period. They tell us if you think that they're at risk for sudden cardiac death, but beyond the ejection fraction, they don't tell us what the criteria are. So to put this all together, Okay, and these are the clues that are within the papers, that are within the guidelines, that may make you suspect that this patient is at risk for sudden cardiac death during that transition period. In the post-MI patient, whether they got revascularized or not, during that 40-day post-MI period where you're cranking up the beta blockers, these are the main, and this is the strongest data, these are the main predictors of sudden cardiac death in this patient population. High baseline heart rate, impaired baseline creatinine, low EF, QRS duration, and elevated BUN. On our stethoscopes, and at least on mine, we all have little notches of patients that maybe didn't do so well. It doesn't mean that you did anything wrong, but they didn't have a good outcome. And at least even before this data came out, on my stethoscope, I had at least 6 patients over the last 10 years that I lost because of sudden cardiac death early on. And I'm Puerto Rican, I'm compulsive. Mira, ¿qué pasó? I go back to the clinical record. And the one thing that came out, even before this data, they were still tachycardic, 110, 100 beats per minute, despite beta blocker therapy. This is the strongest data in the post-MI patient during those 40 days waiting period. In terms of the ischemic cardiomyopathy patient, and this comes from the MADE-2 data, there are 5 risk factors: functional class greater than 2, AFib, wide QRS, age over 70, BUN of greater than 26. A lot of this data comes out in the other registries in terms of risk of sudden death early on after your cardiomyopathy. If you had 0 of these risk factors, you were class 1, your QRS is normal, your kidney function is normal, you didn't benefit from your defibrillator. There was no reduction in mortality. If you had 1 risk factor or 2 risk factors, ultimately you benefited from a defibrillator. And if you had all 5 risk factors, you were so sick, you did not benefit from your defibrillator. You actually died of pump failure before those curves could diverge. And in the non-ischemic cardiomyopathy patient, this is the best data that we have within the papers published in terms of determining who's at risk for sudden death with a new non-ischemic cardiomyopathy patient. Non-sustained VT, but more important, PVC frequency, which is greater than 10 PVCs an hour, or having polymorphic non-sustained VT. There are certain conditions that now with MRIs you can come where, depending on where you have gadolinium enhancement, you can diagnose sarcoid heart disease, giant cell myocarditis, non-compactions. These are conditions that are at high risk for sudden cardiac death. Left bundle or greater QRS duration seems to be a risk factor. And we know that early on, very enlarged hearts will tend less to recover as compared to smaller hearts and functional class 3. So these are some of the risk factors in the non-ischemic patient that you may be able to detect early on. Do we need to crank up the beta blockers to faster to a higher dose? Do we need a wearable cardiac defibrillator? There are things that you can do to protect your patients during this early transition period. So I've tried to, over the last 20 minutes, as you're cranking up the beta blockers and as you're titrating neurohormonal blockade, there are risk factors for sudden death. The guidelines the guidelines don't specifically say what those risk factors are beyond the ejection fraction, but there are different clinical trials that you can kind of sort of predict what these risk factors are. So I leave you with one last quote from Huang Dinan Chang, first Chinese medical text. I'm Puerto Rican, we're in Spain, I practice in Florida, and we're ending with a Chinese quote. That's life. But I think this applies to heart failure and to all the issues that we deal with. Superior doctors prevent the disease. Mediocre doctors treat the disease before evident. Inferior doctors treat the full-blown disease. Heart failure is hard. It can be very devastating and it can be very rewarding. But I believe that during that curve, early on or late on, there are clues that tell us that these patients are at risk for certain conditions, in this case, sudden cardiac death. And I've tried over the last 20 minutes to give you some insight in terms of what these risk factors are. So a true pleasure to be here, many friends and colleagues in the audience, and thank you so much for your attention.
Thank you very much, Dr. Aranda. If you don't mind, for the sake of time, we will keep the questions later. I will have them later. So let's move on to the next talk. The next talk is risk stratification in patients with acute coronary syndromes. And the speaker is José Ramón González Juanatey, our president from Santiago de Compostela.
So, good afternoon. First of all, I would like to thank, and in my first intervention here in this Congress, I would like to give my warmest welcome to our international guests and to all of us to our Congress. Before this afternoon opening ceremony, I'm completely convinced that it will be a very successful Congress. My talk, I will address the issue of the risk stratification in patients with acute coronary syndromes and the clinical implications for risk stratification. Here you can see my disclosures possible related with this presentation. And on this slide, is outlined the clinical evaluation or the clinical strategy in patients with acute coronary syndromes, where the risk stratification plays a critical role. Plays a critical role not only in the diagnosis process, but also in the organization of the patient in the hospital and the selection of the treatment, and also in the follow-up. So the diagnosis is critically, but the risk assessment, the risk stratification is a very important issue in acute coronary syndromes. And the risk stratifications is with the concept of this is a continuum. And this is a continuum not only related with the possible cardiac complications, but also extracardiac complications that can promote cardiac complications, infections, and other complications that can promote cardiovascular complications, and also a directional relation between cardiac complications and extracardiac. All these influence the outcome of the patients during the hospital stay, and possible is a condition or is influence the prognostic, the long-term, medium-term, and long-term prognostic of the patient. How to assess the risk in patients with acute coronary syndrome? This is the guidelines, the new guidelines of the European Society, the non-ST elevation guidelines. And these guidelines divide the risk stratifications in two ways. One, usually you do the risk, we perform the risk stratification based on individual clinical factors. Clinical, electrocardiogram, echocardiogram, lab elements that could help us to stratify the risk in an individual patient. But as was stated in previous guidelines, the risk score, but in these new guidelines, changes the level of evidence. This is 1B. So we perform the risk stratification based on individual clinical elements, or we have to use a quantitative assessment of the risk of the patients based on risk score analysis. And this was assessed several times, and this was a publication several years ago that quantitative model, at least from a conceptual or a philosophic point of view, quantitative models probably are more precise in risk stratification of the patients, not only in acute coronary syndrome, but also in other cardiac, extracardiac pathologies, than semi-quantitative or individual elements in risk stratification. So this is more precise, but this more precise is translated into a more benefit, not only in the follow-up of the patient, but also in the treatment selection and prognosis of the patient. This is the critical point that if this happens, you have to move from an individual elements taken into account in risk stratification to a quantitative or semi-quantitative models for risk stratification. And when talking about the risk stratification in acute coronary syndrome, it's not only the thrombotic or ischemic risk, it's also the bleeding risk and the kidney risk. Not only contrast-induced, that is most important, kidney risk in acute coronary syndrome patients, but also the global kidney risk. 3 risks. How assess this individual risk and how to put into a global assessment, an integrated assessment of these 3 risks. The ischemic risk, the GRACE risk score, and the TIMI risk score are very well known, very well recognized in clinical guidelines, the usefulness of this risk score for the mortality during the hospital stay and after 6 months of patients with acute coronary syndrome, not only with non-ST elevation, that most of in many cases with more use in non-ST elevation patients, but also in ST elevation in infarct patients. But many other elements that is not included in these scores, in the GRACE and in the TIMI score, that was proposed for elements to have to be taken into account with risk stratification. This is the philosophy of taking individual clinical elements for risk stratification. This is a publication, a recent publication of our group, where in patients with an acute coronary syndrome and no angial lesions, these patients have the same risk that patients with a one-vessel disease, and also we propose that in these patients also we have to assess the risk and according with the risk, the follow-up, and not only the follow-up after hospital discharge, during the hospital stay, the selection of the treatment. Also, our group was published, that is in press, that is ahead of print in the Revista Española de Cardiología, the dominance, the pattern of coronary artery dominance plays also a independent influence on the prognosis in the overall population and also in patients after hospital discharge. And you can see that the left coronary artery dominance is associated, independently associated with a worse prognosis. Many other clinical elements was demonstrated with an influence on the prognosis. But which is the additional value that these elements, when you include these elements in the well-established scores, in this case the GRACE or the TIMI score. This is the most important. Not only demonstrate that an individual clinical elements influence the prognosis, but also the additive value of this individual element to a score. Also, our group published that the GRACE score is very robust, assessing the prognosis, the GRACE score related with the hospital mortality, not only in the non-STEMI, but also in STEMI, in the STEMI population, and also 6 months. It's not only in the population used for develop the GRACE, but also in other patient population, the GRACE is very robust. And also what was very interesting in assessing the additive value of new score, the new GRACE and new scores, and we published this in JACC several years ago, and we demonstrate that the GRACE continues to be the risk stratification, the score of choice, despite new risk scores developed in a more contemporary area. At least in our more than 5,000 patients prospectively admitted to our hospital with an acute coronary syndrome, the classical GRACE score continues to be very robust in this risk stratification. And more recently, in the area of interventional cardiology in the vast majority of patients with an acute coronary syndrome, several new scores were developed, particularly in a subgroup population. As you know, the high-risk and very high-risk patients identified by GRACE are relatively heterogeneous. Exist subgroup of patients with a different prognosis, and the risk is dynamic. After an intervention, after a stent implant of other treatment strategies, the risk changes. So new risk scores were developed for assessing these subgroups in the high risk and very high risk of the GRACE risk score. Again, we analyze this new risk score, the performance of this new risk score, and you can see, particularly because the strategy is more efficient in patients with high risk. This is the routine invasive strategy is particularly beneficial in the subgroup of patients with high risk, and we have to avoid the treatment paradox that in clinical practice we treat with interventional strategy, with interventional cardiology in patients with the lower risk. And as you saw, the more pronounced benefit was seen in patients with the higher risk. So, in patients with high risk or very high risk, where exists a heterogeneity of subgroup of patients, this new score, this American score, and this European score could help us to identify patients with high risk in GRACE with low risk, and this is important for the patient strategy during hospital stay and for treatment. We performed this analysis, and was published 3 years ago in JACC, and you can see on this slide that in patients with high and very high risk based on GRACE, this new score can help us to identify patients with lower risk, and that could be discharged for the hospital earlier on, where the treatment could be adapted to this risk. So the new scores are very useful for stratify the patients in the high or very high risk based on the GRACE risk score. And also, we published last year that the GRACE risk score is very robust, not only in mortality and ischemic complications, but also in other complications during the follow-up of patients with an acute coronary syndrome, not only the mortality, the reinfarction, but also the stroke risk and the heart failure. Particularly, the development of heart failure is very well identified based on the GRACE risk score evaluation. And the GRACE had several limitations. One is this, the heterogeneity in the subgroup of patients with high or very high risk based on the GRACE puntuation, the GRACE score. But also, the GRACE is very influenced by the age of the patients. For example, 2 patients, one 50 years of age with this GRACE, another with 90 years old, with the same clinical characteristics, is very influenced, in this case, by the age. So, it's important for our perspective to using in clinical practice a quantitative model for thrombotic risk assessment, and we recommend GRACE, but we recommend other risk scores, but they're very easy to use for identify, particularly in the high or very high risk patients, the low risk after intervention that could be managed more rapidly during the hospital stay. But we have a challenge that the patients have risk not only during hospital stay and early after hospital discharge, the long-term risk, and we propose different scores, 2 different scores that was published also recently in the Revista Española de Cardiología for assessing the risk over the long term from discharge to 1 year, several clinical elements, and beyond 1 year, and again based on a semi-quantitative risk assessment. We need to validate this proposal, and probably this could be useful for the follow-up and for the organization of the follow-up of the huge number of huge population of patients surviving after an acute coronary event. We move on to the bleeding risk. Bleeding risk sometimes is a risk with a more impact on the prognosis than ischemic risk. And again, the new guidelines say that bleeding risk need to be assessed during hospital stay of the patients with an acute coronary syndrome, and propose, as was proposed by the American guidelines, the CRUSADE risk score. This is the CRUSADE risk score. That is a very robust risk score for assessing the bleeding risk. And this is our publication in circulation 5 years ago. For the first time, the CRUSADE risk score was validated in a population outside the population that was used for performing the CRUSADE. And in our population, the performance of the CRUSADE risk score for bleeding risk assessment was extremely high. It was extremely useful, this score, for assessing this risk that is very important during the hospital stay, and not only during the hospital stay, for example, several treatment selections and other interventions. And again, new scores for bleeding was proposed and was published over the last years, the group of Rosanna Merran and other scores. And again, we analyze the comparison between the CRUSADE, the performance of the robust of the CRUSADE, compared with the more modern and new bleeding risk score. We published this in the Acute Cardiovascular Care of the European Heart Journal, and we demonstrate that CRUSADE in a modern treated acute coronary syndrome population continues to be very robust, assessing different risk of bleeding from the very low to very high risk of bleeding. But the patients with an acute coronary syndrome, the risk of bleeding is not only during the hospital stay, continues to be during the follow-up. And we are very interested in assessing the bleeding risk because the CRUSADE was assessed the risk during the 30 days after the hospital admission, only 30 days. But the patients continues to be at risk of bleeding during the follow-up. And based on our patient population, we propose a new score for assessing the bleeding risk during 1 year after hospital discharge, where the CRUSADE was not validated. That is the elements that we identify in our score, and this is the performance of our score. Probably in 1 month we publish a new score, this new score with a multi-center database that we propose a new score for assessing the bleeding risk after hospital discharge in patients with acute coronary syndrome. And this is very important because which is the possible mechanism? There are many mechanisms implicated in this relation between the bleeding risk and the prognosis. You can see on this slide possible explanations for these relations. And the clinical implications of high bleeding risk. For this is the reason why we propose that we have to quantify the bleeding risk during hospital stay and after hospital discharge, because we have to select. There are many clinical elements, but we have to select the approach in interventional cardiology. We have to avoid the excessive dosing or switching. This is most important determinant of bleeding risk of antithrombotics. The combination and the duration of the antithrombotics, because, as you know, recently was published a paper, a clinical trial that suggests that in patients surviving after an acute coronary syndrome could be useful, prolong the anti-treatment, but as you can see, the number needed to treat the beneficial was exactly the same that the number needed to harm, in this case, to produce a severe bleeding evidence. So we have to select subgroup of patients where prolonging in this case, 2 antiplatelet drugs could be beneficial. And this, we think, and I think, that the risk scores, and in this case, the bleeding risk score could be very useful. So, and finally, contrast-induced nephropathy. This is sometimes a neglected risk in clinical practice. All the patients, or the vast majority of the patients, goes to the interventional cardiology where the contrast median was used. Several risk scores, but it is the most important risk score, because the score proposed by the group of the Rosanna Merran for assessing the contrast-induced nephropathy risk. We validate very recent this score in other patient population. Is for the first time after 10 years of publication that was validated in other population. We see that increasing the risk score in the GRACE is related with the kidney dysfunction, the several proposed definition of kidney dysfunction or contrast-induced nephropathy, and kidney dysfunction after interventional cardiology are closely related with bleeding risk and with cardiac events. Probably kidney dysfunction is a key factor in the prognosis of the patient during hospital stay and probably early after hospital discharge. And we propose this figure where kidney dysfunction after interventional cardiology plays a critical role in the evolution, in the prognosis, in the short term, during hospital stay, and early after hospital discharge. And we publish a proposal for the quantity of contrast medium you have to use according with the patient characteristics. And we are convinced that it's very critical. We have to say to the interventional cardiologist the maximum volume of contrast medium that could use in an individual patient for avoiding this kidney dysfunction that clearly promotes more complications. So we have to integrate these 3 risks. Probably in the near future, we have our only score, but at the present time, we have to analyze this risk, but these risks are closely related. So in clinical practice, we have to quantify risk. We have to quantify different risks for avoiding thrombotic events, avoiding bleeding risk, protect the kidney, that they are the 3 major elements that can be quantified in clinical practice and have to influence your strategy in this very important group of patients. And this need to be directed by a clinical cardiologist. The clinical cardiologist is the director of the process in acute coronary syndrome. It's very important. And this director can to orient not only cardiac imaging, but particular interventional cardiology, all the cardiologists for the best risk stratification or for achieving the best prognosis in this very important population. This is my final slide. This is our group where we are very interested in assessing the risk of our patients and based on this assessment propose new strategies with the objective of reducing the mortality and morbidity of our patients. Thank you.
Thank you, Dr. Jonete. I'm afraid we have to move along. If we have time at the end, we will ask questions. And now it's my pleasure to ask Dr. Fausto Pinto to come to the podium. And Dr. Fausto Pinto is the president of the European Society of Cardiology, and he will be speaking on what's new in cardiovascular imaging. Fausto?
Well, thank you very much, Lina, and thank you, Jose Ramon, and the dear colleagues from the Spanish Society. It's a big pleasure and a big honor to be here again. I'm just next door, so it's nice always to come over, be with the friends, and discuss some common issues that we have as cardiologists in our own places, in our own countries, in our own continents. Basically, we share the same goal of improving the way we can do patient management. So I will try for the next 20 minutes or so to give you a little bit of a flavor of what was presented in London. We had a big meeting in London just a month ago. There was the biggest ever in cardiovascular medicine, 33,000 people. And one of the areas where we did have quite a lot of interesting new data, interesting demonstrations of new applications, also new areas looking into the future, it was about imaging. So there was a lot of imaging presentations. And of course, what I will do here is to give you a little bit on a nutshell of some of the areas that were considered as probably more interesting, although it's always a problem when you have to choose. And I have to thank here Victoria Delgado from Leiden. We have what we call the highlights, where at the end of the Congress we select from the 9 different topics the best of the best. That, of course, again, a selection. And Victoria did this for imaging, so I have to thank, because most of the presentation is related with her choices. So I'll divide the talk in 3 main areas where imaging has had important new developments. In coronary artery disease and ischemic heart disease, and I will show from 3 different studies. One it's a trial, the platform trial, and on the use of non-invasive FFR on selection of patients for coronary angiography. The second one is on a new methodology, imaging methodology in the setting of acute myocardial infarction using MRI. The third one on the use also of a new perfusion imaging scoring system using PET, also in the setting of STEMI. Then the second big group will be on heart failure. We'll revisit the ECHO-CRT sub-study. We know this was a negative study presented last year, but there is still some interesting data coming out of the study, and I will show you that. And then there will be a presentation. I will give a little bit of a flavor on the study that used together MIBG and MRI to look at scar and innervation at the same time in patients that were selected for ICD. The third one will be on technological innovations, and I will show you 3 different innovations in imaging. One on the use of CT and a new methodology on calcium subtraction for looking at coronary artery disease. Then fusion imaging, which is one of the hot topics in imaging. And finally, also a hot topic, the 3D printing, which is coming also to imaging and to cardiovascular imaging. So let's start with coronary artery disease and ischemic heart disease. The first study I will show you is the platform study. It's looking at clinical outcomes using FFR, but here is non-invasive FFR using CT-guided diagnostic strategies versus the usual care in patients who had suspected coronary artery disease. As you know, this is a method that has been around for the last couple of years. It's still a research method, but it's quite impressive, the amount of data coming out of this. The initial one was the heart flow coming out, and also the potential use of this methodology on the non-invasive assessment of hemodynamic significant coronary lesions. So what they did here, they selected a group of patients with stable symptoms, with suspicious for coronary disease, and they were planned for non-emergent, non-invasive test or catheterization. They divided in 2 subgroups. One group were patients who had planned a non-invasive test, and the other one was a group of patients who had planned going straight to invasive coronary angiography. And then on each one of the groups, on the one that was planned for non-invasive test, they selected patients who used the standard non-invasive test, either as exercise treadmill, stress nuclear echo, or MRI. And then the other group were the patients who underwent this combined methodology of using non-invasive FFR assessment and CT angiography. And then on the second group, with planned invasive coronary angiography, the patients were divided in two groups. Either they went immediately for standard invasive coronary angiography, or they underwent the CT angio with non-invasive FFR. The clinical results will be available to the care team within 24 to 48 hours, and subsequent testing and management per care team per best practices was decided, and the goals were looking at the catheterization without obstructive coronary disease, or FFR less than 0.8, and also the classical MACE of death, MI, and stable angina vascular events, and so on. So what is interesting here, on the left you see the patients who had planned non-invasive test, and here there was no difference. So if the patient underwent non-invasive assessment, functional assessment, compared with the patients who had non-invasive FFR assessment and CT angio, there was no significant difference between these two groups. The difference was in the other group of patients, the patients who had planned invasive coronary angiography, where the patients who underwent this non-invasive approach, the number of patients that had non-obstructive coronary disease was much lower, meaning that with this methodology was actually able to select better the patients who will probably benefit better of having an invasive strategy. So for patient selection, probably, and again, we are still, I would say, at the beginning of this technology, but probably this technology can be very useful for patient selection that will undergo coronary angiography, and eventually even to pre-select the lesions that will be subsequently treated by coronary intervention. Again, this still needs to be proven, but this is certainly one important step forward on this non-invasive technology that can actually assess non-invasively the FFR, meaning the hemodynamic significance of coronary artery disease. Now, the second study was on the use of CMR, cardiovascular magnetic resonance, looking at some interesting aspects related in the setting of acute myocardial infarction. We know, and this is a new technology which uses this specific methodology based on magnetic resonance imaging. And here was looking within the infarct core in the first 2 weeks following acute myocardial infarction, assessing and monitoring the amount of myocardial cellular inflammation. And here looking at aspects related with diagnosis, with potential risk stratification, and potential also, as you know, this is also an important area even from a therapeutic standpoint, and potentially developing novel anti-inflammatory therapeutic targets, meaning potentially new therapeutic interventions. This is again some new data, some new way to look at inflammation. Here basically shows over time, and on the x-axis and on the y-axis the response. We can see in the initial stages of STEMI, the amount of macrophage infiltration, and then over time we can see the amount of tissue edema, leaking capillary that can be detected by this methodology. So again, looking at the amount of inflammation after myocardial infarction, and potentially setting here new methodology that can help, again, on diagnosis, on risk stratification, and potentially looking into new targets of anti-inflammatory therapeutic strategies. Now, the third one, still in the setting of an acute myocardial infarction, was using this new index. It's called the perfusible tissue index, PTI, that was studied at baseline, and then compared this with the classical images of MRI using late enhancement gadolinium, and basically here was trying to identify, again, new methods that can help us to predict recovery of left ventricular function, which, as we know, is one of the questions that we have in the setting of these patients. And in this case, a cutoff value of 0.85 for this index, for this perfusible tissue index using this methodology, was optimal for accurately predicting regional functional recovery. So again, opening the way for a new imaging methodology that can help us to look at risk stratification, and in this case, at prediction of recovery of left ventricular function after an acute myocardial infarction. Now let's talk a little bit about heart failure, and here a couple of studies, as I've mentioned. One of them was the echo-CRT. As you may recall, the echo-CRT was trying to look at patients who had narrow QRS but had from echo evidence of desynchrony if the use of CRT in these patients will be advantageous. And as you might recall, this was a negative study, was actually interrupted, and that was presented last year at the ESC Congress. Now, what they did here, and this is the subgroup analysis looking at the echo data, John Gorson from Pittsburgh, what they presented here, they actually went back and then went to look at the population and divided in two groups of patients. So the patients who had persistent significant desynchrony and the patients who had no significant desynchrony at 6 months follow-up. And they selected a group of, and these were about 600 patients, and what they showed was that after 3.5 years of follow-up, there was a significant difference in terms of outcome or prognosis, with the worst prognosis in the group of patients who had persistent significant desynchrony at 6 months. So again here, and again this is a sub-study, and it's a post-hoc analysis, and I do know that many people are not so happy with this kind of analysis, even from a statistical standpoint. But anyhow, this raises the question again about, and actually what shows here is that persistence of significant desynchrony does seem to have prognostic implications in this patient population. And again, I recall that these were patients with heart failure but who had narrow QRS. So it does not give additional information in terms of the indication for CRT. That was not the purpose, but it does provide some potential clinical indication that at least in the subset of patients who had persistent significant desynchrony, probably there is something there in terms of prognosis in this patient population. Now, the other interesting study coming from this country, from Valencia, was a study about 86 patients, and here they had a combination of MRI using late gadolinium enhancement and MIBG to look at innervation, MIBG SPECT to improve risk stratification again of heart failure patients. And what they showed was that the combination of these two methodologies could actually improve the way that it could do risk stratification in patients with heart failure. So, and you can see here on the bottom. So demonstrating, or at least raising this interesting point that using a combination of these methodologies, which provide you different information, can actually be useful for risk, might potentially be useful for risk stratification in patients with heart failure. Now, let me give you a little bit on some technological advances. And as we know, imaging is quite dependent on new developments in technology, and that's why it's so important, this combination of clinicians, of clinical questions, and then together with our technological colleagues to develop some new areas in imaging. This is work also coming from Spain, from Barcelona Group, and is looking at the use of CT. It's a new post-processing method, and the point here was looking at coronary artery calcium and metal stent subtraction using a 320 slice CT. And what they did here, and you can see here the pre-contrast CT angio, and then a subtraction, and then this is the final image. And what they showed here, what you can see nicely here, the conventional CT angio, and then with this new post-processing, where you can see much nicely, particularly in patients who had stents, the luminal images, and here you have the comparison with invasive coronary angiography. So again, potentially highlighting the relevance of this methodology. We know that in some of these patients, it might be very difficult to have good non-invasive imaging, and for patient selection also this can prove to be quite relevant. Using this methodology, you might overcome, and again, this is an initial study, but you might overcome some of the limitations that we have with the conventional CT angiography to look specifically at some subgroup of patients, particularly the patients who underwent stent placement. Now, this is quite a fascinating new area of fusion imaging. This is the so-called smart fusion imaging. It's still a prototype with potential clinical applications in cardiovascular medicine. So the whole goal here is trying to take advantage, like in any fusion imaging, to take advantage of the potential of each one of the different methodologies. More spatial resolution in some methodologies like CT or MRI, better temporal resolution in other methodologies like ultrasound. And here you have an example where you can see together on the left side, the image is taken with MRI, and on the right side, you can see the image is taken with echo. This is a patient with an AST, and you can see nicely here, and this can be obtained with this prototype, demonstrating the potential use in the future of this methodology, where you can, again, have a full screening and a full study of a patient, both from an anatomical and from a functional standpoint. So certainly one area, very exciting. Other fusion imaging, PET-CT, PET-MRI, there's a lot of new developments in the combination of different imaging methodologies with potential future clinical applications. And then the other one is the use of 3D printing, which is also becoming quite fashionable and in different areas. In this specific case, it's a group from Italy. They went to look at the tricuspid geometry, which we know can be quite challenging, particularly with 2D imaging. And they went to look at the feasibility of 3D printing of the tricuspid valve by using transthoracic 3D echocardiography. And you can see here the results. It's quite interesting, quite fascinating, this 3D printing. This might be quite useful, for instance, for strategies of surgical interventions, for planning of certain procedures to understand better the anatomy of, in this case, of the tricuspid ring, but potentially be applied to other areas. So one area to keep tuned, looking into the future of 3D printing in cardiology. So I would summarize by saying that in imaging, as I've mentioned, there were many studies presented. This is just a very short overview of some of the areas in 3 different topics, again, on ischemic heart disease, on heart failure, and also on technological innovations. We can say that the combination of anatomical and functional data by using non-invasive FFR, so-called FFR-CT, on coronary artery disease seems to improve the referral of patients for invasive coronary angiography, and you can immediately imagine here the potential use of this in such a huge population that we have to treat. And if we can do better patient selection, this can prove to be quite an important clinical tool. Also, some new insights on novel pathophysiological aspects of myocardial infarction, revisiting the whole concept of inflammation in the setting of myocardial infarction with objective evidence by using some new imaging methodologies that can provide better insight into the inflammatory changes in the acute setting and the follow-up in these patients. Then, in the setting of heart failure, the left ventricular desynchrony after CRT is associated with worse prognosis, and there's probably here some more areas of study in this patient population. The integration of myocardial scar by using MRI and the late gadolinium enhancement and innervation imaging by using MIBG SPECT, it seems to refine the risk stratification of heart failure patients, puts together actually quite a lot of previous information we had by using these 2 technologies separately. And then finally, the use of fusion imaging and 3D printing. It's a growing field, and certainly there's a lot to come that can help us to improve the way we can do patient management. Because at the end, as cardiologists, that's what we are interested for, is how much these different technologies can help us to better treat our patients. And just a reminder that next year Congress of the ESC will be in Rome, 27th to the 31st of August, and the spotlight will be on the heart team, which I think is quite appropriate. And we certainly looking forward to have a big Spanish component at our Congress. So thank you very much. Muchas gracias.
Thank Thank you. Thank you, Fausto. We have here some questions for you that Dr. Quiles will propose to you.
Coming from Twitter, Dr. Jose Juan Gomez is asking you about two questions about imaging. The first one, is ECHO dead in the search of CRT candidates?
Can you say again, sorry? Is ECHO?
Is ECHO dead in the search?
Is ECHO dead? No, ECHO will never be dead. And we will do some CPR on ECHO if we need. I actually think that the use of, we do know that in the guidelines, it's still, there is no role of ECHO because it's based on the three indications which are clinical and based on the ECG and on the assessment of EF, which can be used by any imaging technique. But I think, and there were some trials in the past that were not so positive and in a way have given a little bit of a bad image to ECHO. But there are a lot of groups working on new methods and new ways. There were many limitations on some of the studies where the use of ECHO was performed in patient selection. I'm one of the believers that there is some more to come, and certainly ECHO will not be dead in the assessment of these patients. But we need more work to do.
Thank you very much, Fausto. Thank you.
Okay, we are sorry, but we have to finish this session that is with the European Society of Cardiology, American Heart Association, ACC Florida. I would like to thank the speakers for the night talks and all the audience, not only here but also through internet, for their interest and questions. Thank you very much.
No queda tiempo para hacer preguntas. Están muy ajustadas las...